So I want just to get an idea of the kind of audience we have today. I want to see how many of you are preparing for the USMLEs. And I think it might be easier if you just type in the chat box. Just type a yes if you are preparing for the USMLE step 1, or whichever step if you are preparing for any of the USMLE steps. I'm going to give you about 45 seconds. Right, I see a number of yeses. Janice, thankfully, no. Of course. Yes, say Ratish, Halima, Rita, Pauline, Kamau. I have to call you Pauline after this. Judy, of course, come on. All right, I think I'm going to just, we'll approach this session as if there is clinical material to learn. All right, there's clinical material to learn that people could pick, but apart from that, I'm going to mostly just present this material as though we are preparing for the steps. Now, this is my principle when it comes to learning anything, that the first thing you need to learn is the roadmap. It's the roadmap. I sometimes think that we can waste time when we are trying to learn something, especially for the first time, if we try to dig into the details before we have a roadmap. Judy and I, during our first 2 years of medical school, we studied together quite often. And the one thing I found that she did, which I also did, was focusing on the roadmap, taking a topic and knowing the outline of the topic. Because if you know the outline of the topic, then you can tell which sections of the topic you need to review. Because it's very easy for you to waste time reviewing something you already know, when you should be spending that time digging deeper in the areas that you don't know. And so I am a firm believer and practitioner in taking any article I'm reading or textbook I'm reading, and first of all, truly know offhand what the topics are covered in that textbook or on that article. So what are the topics covered? And then the next level is, what are the sections in each of these topics? So if, for example, today we are speaking about cardiology, and I'm preparing for the USMLE step 1, the question is, what subtopics in cardiology am I supposed to know? And under each of those subtopics, what are the testable concepts? So that is the next level. What are the testable concepts? The testable concepts might be, for example, the drugs. And then from the testable concepts is what are now the specific details. So if the concepts are, for example, the medications, classify the medications, because if I can't classify the medications, when I'm given a question that requires me to specifically select a certain medication, I would have trouble. But even if I don't remember the specific medications, if I know the sections, the answers given to me, I can even eliminate them just based on what I know from that topic. So let's try an example of cardiology as covered in Pathoma. For my study for the USMLE step 1, I used Pathoma extensively, and of course the first aid for the USMLE. So I'm going to take you to Hussein Sattar's Fundamentals of Pathology, and we will use 2 of those topics in there. So this session is essentially cardiovascular, and in his book he has 2 chapters, one on vascular pathology and the other one on cardiac pathology. So I will share my screen, and could I please see by indication of hands, wherever you are, those, especially those studying, please confirm that you have a place to write, you have some space to do rough work where you will scribble out stuff. Could I please see in the chat box? I'm doing this just to make sure that you guys are active. Because if you just listen, it's a waste of time. But if you actually have a place to write, I need you to have a place to write, a pen and some space, whether it's a book or just some sheets of paper on which you can scribble out and write stuff. If you don't, please grab one. Otherwise, this becomes it becomes just something that you hear and it goes away. Okay, hopefully most of you, especially those of you who are preparing for, Janice has one that is pink. Yes. All right, let's go. And I'm going to share my screen. And that is vascular pathology. And so we will run through vascular pathology probably 2 or 3 times. And we are going through it as though I am also studying for this exam. And just so that we dissect this chapter a little deeper. Okay, so vascular pathology. So we'll just look through. You don't need to write anything right now. Vascular pathology is covered by Hussein Sattar in his book, Pathoma. So the topic is vascular pathology. The segments, as we scroll through, you will see what the segments are. So vasculitis, the definition of vasculitis, nobody's going to necessarily test you on that. But the big concept here is that vasculitis can be classified into 3. That's large vessel vasculitis, medium vessel, and small vessel vasculitis. And the main difference is that the muscular arteries are the subdivision. So remember that is the overall subdivision. Then under large vessel vasculitis, you have temporal giant cell arteritis, you have Takayasu as the 2 main ones. They share a lot of features across each of them, but they have differentiators. Medium vessel vasculitis, you have Polyarteritis Nodosa, Kawasaki, and Voyager Disease. You may pronounce it very differently. Something very specific about Voyager Disease, its association with smoking. And you have small vessel vasculitis, Wegener granulomatosis, microscopic polyangiitis, Churg-Strauss syndrome, and Henoch-Schönlein purpura. So on the space you have, can you write down, you have large vessel, medium vessel, and small vessel vasculitis. Can you write down what the types you remember under each of the 3 categories? And as soon as I see yes, 2 yeses from some of you guys, we will move to the next section. Because that is the power of learning actively. If you can reproduce this, when you go back to read the specific details under each of them, it becomes very easy. So please write down those types. And as soon as you are done, please type a yes as we see 2, right? Okay, hypertension. Hypertension is fairly straightforward. There are concepts which are tested directly. I mean, it's primary hypertension, secondary hypertension, but the most important part of this is to look at the common causes of the secondary hypertension and what workup would be done, and then differentiate between benign and malignant hypertension. And a further concept that is not in this book is something that when you practice clinically is very common. That's hypertensive urgency and hypertensive emergency. Right? Remember, we are still in vascular pathology. So let's look at arterial sclerosis, the hardening of blood vessels. Arterial sclerosis is subdivided into 2 types. There is atherosclerosis, and then there is arteriolosclerosis. One of the more important concepts that are tested in this area relates to what you will see in cardiac disease, but prevention, modification of risk factors by use of medications such as statins, lifestyle change, that would be tested. And then now most of these concepts will cross over to cardiology in terms of how the complications of what I'm highlighting here, how these complications lead to cardiac disease and sometimes lead to other pathologic manifestations, especially in the kidneys and peripheral arterial disease. The part you also would need to pay attention to in this section of the vascular pathology is arterial sclerosis, especially as it relates to comorbidities such as hypertension and blood pressure. So the important thing is to be able to, off the head, remember, so that your aim is to come to a time when you can flip through this book, Pathoma, within an hour, and you enhance, because you'll open a page and you're like, I know this part, I don't think I know this part, so that you review the parts that you don't know as well. And this is a book that I ended up knowing almost back to front, and it's changed my performance on the USMLEs. Now, Mockenberg is very specific. Whenever you will see it tested, it will be a very, very specific question. And the time I've seen it in any of the main exams, but the times I've seen it in the question banks, you have a picture of a vessel with, you see this picture in the middle looks something close to that, with a lot of calcium deposits on the muscular wall. And you will have an image accompanying it. So atherosclerosis and arteriolosclerosis are the main things in arteriosclerosis, where arterial is just the hardening. Arterial relates to the small vessels, and atherosclerosis affects the bigger vessels. There isn't much for us to even do there, but just remember those three, and then of course Monkenberg. Aortic dissection. There are three layers in on the structure of the aorta's wall. Remember those three, and remember which layer is affected, right? And then what correlations you will be tested on. And we'll come back and look at those. There are two types, thoracic and abdominal. In surgery, they call them type A and type B. It's the same thing. Then you have the tumors, which concludes this chapter. The important one here is the Kaposi sarcoma. And then in dermatology, you will see certain types of hemangiomas, such as cherry hemangioma. But the important one here is angiosarcoma. And of course, its associations, right? Okay, so let's run through this, just one more, and see what are some of the more specific details that we need to pay attention to. So we're essentially reviewing this chapter together, right? So in large vessel vasculitis, I'm just going to ask you a couple of, off the top of my head questions, and to see what you know. So, for example, let's go through temporal. That is under the large vessel. You have these two under large vessel vasculitis: temporal or giant cell arteritis, and Takayasu. Now, I'm hiding this so that it doesn't create issues. There is always a confusion between Takayasu and Kawasaki. Takayasu and Kawasaki. This, in any USMLE Step 1 exam you do, you will have both or at least one of them. So now we know there are three categories. There is large vessel, medium vessel, and small vessel. Takayasu is a large vessel vasculitis. But what are some of the clinical features that come off the top of your head when you think about Takayasu? And you're not going to, don't type anything, just write down like 2 or 3 things, but actually write down something, 1 or 2 things. Or at least think about it. And then the other one under large vessel is giant cell. When you think about giant cell, if you start reading a clinical scenario, what tells you that this is giant cell arteritis? So for giant cell, you should remember that there are two types, which is not mentioned here. There is intracranial and extracranial giant cell arteritis. Most of the time when we think about giant cell arteritis, which we call temporal arteritis, we think of a patient presenting with a unilateral headache with loss of vision on the affected eye and tenderness. And of course, you will do biopsy and you will give them corticosteroids, which is what you will see discussed here. So most of the time it's a lady, it's a woman, more than 50 years old, who presents with visual disturbance and headache on one side, on the same side that is affected with jaw claudication. They will have elevated ESR. The question that I have seen, and of course I'm not going to identify where and for obvious reasons, because some of these questions have been in settings from which I'm not supposed to share material out, but the one variation of temporal arteritis that you're likely to miss in the exam is when they present you with all the clinical features. For example, elevated ESR, they give you a 50-year-old woman, but they don't give you the features associated with the temporal artery itself. They don't give you headache on one side, they don't give you change in vision, but then they don't give you other features that could suggest that this is Takayasu. So there is aortic giant cell arteritis. Because this is a large vessel arteritis. So let's remember to take it beyond what you see up here, what you see on the temporal artery. And then I've seen Muthoni Mwangi, that's an extremely important association. It's an extremely important association. It's the association between giant cell arteritis with polymyalgia rheumatica. So what happens is that they will present to you a patient with polymyalgia rheumatica, but they give you vascular symptoms, excluding the symptoms that you have up here. And in this case, one of the most common questions you'll be asked is, what is the next, what is when you think about the series of treatment, what goes first? Of course, diagnosis is extremely important, but steroids go first. Whatever you do, steroids go first. It takes up to 2 weeks for the pathological changes in the artery to disappear. So you give steroids as soon as you can, because otherwise you'll lose vision on that side. So the other one is Takayasu. Takayasu, so the main difference is the age. Takayasu will occur mostly in younger people. Unfortunately, for some reason, this vasculitis occur more commonly in women. ESR is elevated in both, and it can affect, it's large vessel disease. It can affect the same part of the large vessels, but most of the time you differentiate them based on the association of temporal arteritis with polymyalgia rheumatica and the age. Otherwise, whenever I have rotated in rheumatology, the rheumatologists will tell you that they don't know whether it's Takayasu or temporal giant cell arteritis. For example, if you have a 48-year-old, that is so close in between the ages. So you would use this differentiators, otherwise they can both be the same. But in the exam, they will be totally presented to you in a way that you can differentiate them. Temporal arteritis will always be presented alongside with polymyalgia rheumatica, or they will present it so classically with jaw claudication and unilateral headache and loss of vision that you can't miss it. You treat all of them with steroids. You start steroids as soon as you make the diagnosis. You proceed from there. Medium vessel vasculitis are sometimes the more confusing ones. Remember, I asked you the question in terms of what's the difference between Takayasu and Kawasaki. You see, Takayasu happens, it's an adult disease and it affects the large vessels. Kawasaki is a small vessel disease. It's mostly in children, and it will have extensive mucosal surface involvement. You have conjunctivitis, erythematous rash of the soles and palms. You see that number 2 over there, that's what I'm speaking about. So there is extensive. If they present a patient to you, a little boy or girl who looks like they probably could be having a URI, but then they mentioned that this child has red eyes, they have mucous membranes are inflamed, this child is very sick, has high fevers and is crying, and then they ask you what is the most, like somehow they lead you to thinking about what's most likely to happen in terms of vascular complications. They are asking you about coronary artery involvement, because these children end up with coronary aneurysms. And later on, you would find a 7-year-old, 10-year-old having a myocardial infarction. That's because they suffered Kawasaki when they were younger. So Kawasaki coronary, that sound might remind you Kawasaki coronary, but Takayasu, I think of Takayasu, it has so many A's, Takawata, Takayasu. It helps you remember that Takayasu is a large vessel disease. Kawasaki is a small vessel disease, and it's a child who is very sick, and they have inflammation everywhere, from the eyes, the mouth, the palms, the soles of their feet. The whole child is inflamed. That is Kawasaki. If the whole child is inflamed, everything can be affected. The most lethal consequence is what happens to their arteries. And the most specific question you will be tested on is coronary aneurysms and its association with myocardial infarction later on. The first one that we skipped is Polyarteritis Nodosa. The one specific question you will be asked, what is the one association that you will be asked about in Polyarteritis Nodosa? Can somebody type it? And I hope you guys don't have your pathoma open, because then we are running around in circles. Please don't open your own pathoma. All right, Pauline, hepatitis C virus, and Sheila, Ruo, fibrinoid necrosis, Maro Ahmed, hepatitis B. So the answer is hepatitis B virus. Its association with hepatitis B virus, and you will see that up here. So fibrinoid necrosis is the pathology that you will see, and if they give you a picture of fibrinoid necrosis, you will see a blood vessel with a wall that is full of fibrinoid material. Like you'll see a lot of pink in that wall. So it's a necrotizing vasculitis that involves a lot of organs. So this shouldn't, it can happen in any age, but mostly it will be present in adults. So the symptoms will be, you will have a diffuse array of symptoms. The most common thing they will ask you is the association with hepatitis B virus. And this, you expect that they will have an active hepatitis B infection. Therefore, you will see the surface antigen present, which means they are infected. Of course, remember when you think about hepatitis B, if you see the envelope antigen, it means there is active replication that is going on. And if you see the surface antibody, it means that patient is immune to hepatitis B. So when you see the hepatitis B surface antigen, it means there is infection. You don't know whether it is acute or chronic, but there is definitely infection that is going on. The other association that you will be sometimes be tested on, for example, they give you this case and they tell you this patient was put on appropriate treatment. They present to you Polyarteritis Nodosa and tell you the patient was put on appropriate treatment. And what complication do you anticipate? Anybody? What complication would you anticipate to happen from the appropriate treatment? Because that's how USMLE questions will appear to you. It's never straightforward. They give you a case scenario, then they go to the next step and they perform the next step for you, then they go to the next. So the question is, what is the appropriate treatment? The appropriate treatment is Schiller-Roux, yes, that's correct. So the appropriate treatment is a combination of steroids, combined steroids with, anybody? It's going to cause hemorrhagic cystitis. So what's that? Yes, cyclophosphamide. So you treat it with cyclophosphamide. So again, temporal arteritis, we associate it with polymyalgia rheumatica. The main difference is that it appears in older patients, and you differentiate it by the age, and also if you are given classical symptoms. Otherwise, it can be either that or Takayasu. And the difference between Takayasu and Kawasaki is Takayasu is a Takaota. It's in the bigger vessels, and Kawasaki is in small vessels. Polyarteritis Nodosa, its association with hepatitis B, you treat it with cyclophosphamide, which can cause hemorrhagic cystitis, as Schiller-Roux mentioned. The next part is Kawasaki, which we've already spoken about. The child is inflamed from head to toe. Treat them with IVIG. The next one is Voyager disease. What is the most common association with Voyager disease? Anybody? Yep. Oh, you guys are on fire. It is associated with Voyager disease. What is the most common way that this would be presented to you? It will be a patient who has DASH syndrome. What is the name of the syndrome? Because I remember seeing a question like that. So claudication is a possibility. Blue toes. So blue toes can appear because of ischemia. But what is the other thing, the other reason why we sometimes have blue toes? Especially when there is a change of temperature. Yes, Raynaud's. So gangrene is a vascular phenomenon, and gangrene is irreversible, but Raynaud's is not a vascular phenomenon. So Voyager disease associated very highly with smoking, and the treatment is smoking cessation, period. I think we have dissected that. All right, so once again, just by the time you leave this chapter, you will hate vasculitis because we'll have run through that so many times. Temporal arteritis, giant cell arteritis, and an old lady with headache and visual loss, and can be associated with polymyalgia rheumatica. Treat with steroids as soon as possible, do biopsy. Takayasu is almost the same presentation except for the cranial. It doesn't go up to the head, the Takayasu. It's actually the same disease, but it is differentiated just because of how much severe the complications of temporal arteritis can be when they involve the temporal artery. Medium vessel disease, you just need to remember 3 diseases under here. Polyarteritis Nodosa with hepatitis B, and Kawasaki with the heart. Voyager is a very specific question. It's a necrotizing vasculitis. Quit smoking. This part, the small vessel vasculitis, is extremely important. I promise you 100%. In those 300 plus questions in any step 1 exam, you will have at least 2 of this, at least 2. So of all the small vessel vasculitis, there is only one of them has C anchor. Which one? Guys, I really want to insist that please don't use any reference material when we are doing this. Because if you use any reference material, you will just be wasting time. And this is for your integrity and my integrity. Don't use any reference material, please. Because then it's some of the places where we will struggle, it will help you and I. Because when our mind searches for an answer and it can't find it, when we go back to review, That is the first thing the mind is looking for. So Voyager is associated, it's the only one in which we have C anchor. Which one doesn't have any, you don't need to do any anchor testing? Remember, there are 4 of them. So in other words, what I'm doing is I am presuming that we already know the 4. We already know what the 4 are, and then now the specific questions under each of them. And that's why it's extremely important to know, the outline, what the outline is. Then you can fit in the specific points. All right, good. We are ready to go through all of them. I see all the answers from MT, I don't know the full name, Rita, Irene, Captain A, Maru Ahmed, Doreen, and DC. I know all these people, but we have never met face to face. All right, so here we are. Let's go through the small vessel vasculitis. So Voyager granulomatosis, it has a new name, but that is for rheumatologists to deal with. We'll just keep going with this. So the important thing to remember about Voyager is how extensive it is. The parts, the bigger difference between Churg-Strauss and the clinical in terms of manifestation, the bigger difference is that Voyager granulomatosis is the only one with the C anchor, and it's the only one that affects the nasopharynx. So if you have a patient with chronic rhinitis, for some reason, they have hematuria, they have hemoptysis, that begins to point you towards Voyager granulomatosis. A middle-aged man with ulceration up here, hemoptysis down here, and blood. So blood in here, blood in the nose, blood in the lungs, blood in the kidneys. You are thinking Voyager granulomatosis. So they have glomerulonephritis. They have, they can have pulmonary hemorrhage, or they have some pathology going on in the lung from the presentation you are given, and they have something going on up here. You biopsy them and you give them cyclophosphamide and you give and steroids. Anticipate hemorrhagic cystitis. They are the only ones on whom you will find C anchor activity. Voyager granulomatosis. Microscopic polyangiitis. Which organs are affected by microscopic polyangiitis? Any answers? Which organs are affected by microscopic polyangiitis? And which anchor are you looking for in microscopic polyangiitis? Yep, it is kidney, it's lung, it is P anchor, polyangiitis and P anchor. That's a very easy association. Voyager, sometimes I used to call it Voyager granulomatosis to remember the C anchor, and this is microscopic polyangiitis and the P anchor that is found in it. So multiple organs, but most classically, you will be presented with symptoms in the lung and in the kidney. So if they give you a patient who has hematuria and hemoptysis, but they don't give you something to do with rhinitis, they are moving you away from Voyager granulomatosis, moving you towards microscopic polyangiitis. It is called polyangiitis because the angiitis can be anywhere. Polyangiitis, P anchor, lung, kidney, you exclude the nasopharynx. Churg-Strauss, what organs are affected by Churg-Strauss syndrome? What organs are affected? What is the main type? What is the main type of immune cell you will see in Churg-Strauss? It is, so you will see eosinophils. what type of, what immune molecules do you anticipate to be elevated in Chang-Strauss? You guys are running with this. All right, let's review it. Necrotizing granulomatous disease that can affect multiple organs, but especially the lungs and heart. So now we have three of them. If you have the nose, you have the lungs, and you have the kidney, that is vaginal granulomatosis. If you're only given the lungs and the kidney, that is P-ANCA, which is polyangiitis, microscopic polyangiitis. If they don't give you the kidneys, that is Chang-Strauss. So in other words, if they keep you only within the chest, if everything that is being affected is in the chest, that is similar to asthma, which is another association, and you expect high eosinophils, that is Chang-Strauss. Chang-Strauss, chest only, lungs and heart. If they give you nose, lungs, and kidney, that is vaginal granulomatosis. Even the name is so long, it extends from the nose through the lungs all the way to the kidney. But if they give you the kidneys and give you the lungs, but they don't give you the nasopharynx, that is microscopic polyangiitis. And the last one is Henoch-Schönlein purpura. What molecule do you anticipate in Henoch-Schönlein purpura? And what's the biggest symptom you have to look for? Yep, there you have it. You guys are really, I love that you are actively engaging. I would like to see more people engaged. Here we are. So it's skin. If you see skin, you anticipate that this is, so it is purpura. These are not petechiae. Petechiae are, so the clinical presentation, when I have seen this clinically, it is the presentation can be confusing because you have, it starts off with micropurpurae, very tiny purpurae, which then grow up so that now it becomes an obvious purpura. So initially it looks like it's petechial bleeding, because if it's petechial bleeding, anytime you have petechiae, you think platelets, petechiae platelets, those microscopic bleeds. But when you have purpura, it is most of the time something vasculitic. So in this case, you're speaking about Henoch-Schönlein purpura. It is, you will be tested about its association with the GI manifestations, and you'll be tested about skin. You might be given a skin sample, a picture of the skin, and of course it's IgA. So we have covered all the three categories of the vasculitis: large vessel vasculitis, temporal or giant cell arteritis, elderly woman, hurting one side of the head with losing vision, and their ESR is elevated. If those features are not present, you might be being directed towards Takayasu. Remember, Takayasu, Takaota, that is a big vessel and it's different from Kawasaki, which we'll see in the medium vessel disorders. You treat both of them with steroids. Medium vessel disorders, you have Polyarteritis Nodosa, which you will see in multiple organs. Kawasaki, and you have Voyager. Voyager, stop smoking. Kawasaki, do an echo during the time the child is having the presentation. So the next step is usually echo during the time the child is having the active disease, and then the child will require follow-up with 6 monthly echoes. So you won't be tested about how frequently you need to screen, but echo to follow up this child. Remember, Polyarteritis Nodosa, it's a fibrinoid necrosis and its association with hepatitis B. Small vessel vasculitis, vaginal granulomatosis, nose, lung, kidney, C-ANCA. cyclophosphamide, hemorrhagic cystitis, microscopic polyangiitis, P-ANCA, and treat the same. Involves the lungs and the kidneys, spares the nostrils. Churg-Strauss syndrome associated with asthma, eosinophils, and it is P-ANCA. Spares the nostrils or the nasopharynx and spares the kidneys. P-ANCA. So P-ANCA in polyangiitis, microscopic polyangiitis, and Churg-Strauss. C-ANCA for Wegener's granulomatosis, and IgA in Henoch-Schönlein papura, which will present with papura. Henoch-Schönlein papura, this clue is in the name. Papura are palpable phenomena that you can feel under the skin. That will be tested. Most of the time, we don't even treat those. Do you feel confident that if you saw a question on vasculitis, that you'll actually nick it, and that the next time you go back to this book, that section won't take you time, because you just need to remind yourself of the specific things? Can I see anybody? Is this structure useful? Would you prefer we try a different structure? We do a different structure, or is it okay?
Doc, I think I like it. That's amazing. Yep. And I think you used a good concept when you were revising for your exams. You scored very high. I think I should have talked to you in advance.
Yeah, thank you. All right, good. I see a good response. In hypertension, we won't have a lot to do here. My goodness, I can't emphasize how important vasculitis is going to be. You will not miss 2 to 5 questions. 2 to 5 questions. I'm not going to give you the exact number of questions I had, but there were more than 4. And I remember what those questions were. It's extremely, extremely high yield. But not only for this exam, but it also makes you a different kind of clinician. When this lady who is 65-year-old has been being treated for migraine comes in, and this time round you are able to examine the vision, and you find that the vision is blurred on one side, you palpate, you find what's going on, you get an ESR and it's elevated, and you are thinking the next step. That's what makes you, takes you a step ahead of where the nurse would have stopped. Being able to, seeing blood in the urine, and you go beyond prostate cancer, being able to think slightly further ahead, so that, because vessels are everywhere. You see this patient who is being treated for asthma and it's not improving, you test and find that they have very high peripheral eosinophilia, and here you are, this guy has been put on anti-TB medications for 6 months. There's no improvement. They're on asthma treatment. It's not improving. You suddenly are beginning to think about Churg-Strauss syndrome. Start treating them, and they actually improve. That's what makes you a clinician that's able to go beyond where everyone else is stopping by mastering some of this material. All right. So hypertension. The most commonly tested concept in hypertension is secondary hypertension that is due to hyperreninemia. And hyperreninemia can be from, that's high renin, can be from a multitude of factors, but the most commonly tested one is causes of unilateral renal artery stenosis. Different types of causes of renal artery stenosis. You put a patient on ACE inhibitors and their blood pressure, instead of getting better, gets worse, and their renal function gets even worse. That will be tested. And the other, so the question is, what is causing that? So if you're given a young lady, if you are given a young patient who has, I mean, young people shouldn't be having secondary hypertension, very severe resistant hypertension, which is what we call renovascular hypertension. If you look at, on this page, look at the last point number 5, actually in C, atherosclerosis in the elderly or fibromuscular dysplasia in young females. Those are the two concepts that you need to remember that would be tested. So for example, I have seen a question where you are given an elderly patient who has claudication when they walk, right? And then they are hypertensive. They are put on a combination of regimen, including ACE inhibitors. Instead of improvement, their hypertension worsens. The reason is the kidney that is on the side where there is atherosclerosis. Remember, if there is atherosclerosis in the legs, it means any arteries can be involved. So on the side that is affected, when you put them on antihypertensives, that kidney receives even less blood flow, which means it ends up producing even more renin, which activates the renin-angiotensin-aldosterone axis and makes the hypertension worse. And that leads to resistant hypertension. So elderly patient with any risk factors for atherosclerosis, you anticipate that they have atherosclerosis of the renal arteries, especially when it's unilateral, that would cause resistant hypertension. The other one is young females with fibromuscular dysplasia. So if I have a physical book, I would circle those two, because once you've understood everything else under this primary and secondary hypertension, those are the two associations you need to remember that would end up to be tested. Okay. Then the other question about benign and malignant hypertension, just need to remember the definition of hypertensive urgency and hypertensive emergency. Severe elevation of blood pressure is urgency by itself. If there are symptoms, it is emergency, and organ damage symptoms. Then let's go to arterial sclerosis. It's an area that could be tested. A lot of the times, whenever I have seen questions, they tend to have questions which have images associated with this part. So let me see whether there is any specific association that we could speak about. This I will leave this for you to review, because there is no specific question that stands out. One important one I could mention is a patient undergoes some vascular procedure of some type, and they end up with acute respiratory distress or acute hypoxic respiratory failure. So the question is why? So the embolization resulting from vascular procedures is a common thing that you would be tested on. Patient presents with shortness of breath, and they had some procedure. Maybe they had repair of aortic aneurysm 2 days ago. So you just need to remember that embolization of cholesterol molecules through the blood vessel, they land in the lungs and they can cause ARDS. Everything else in this section is fairly straightforward. I do not see anything that specifically need to remember. With regards to aortic dissection, two types of aortic dissection. The most important things to remember here is Ehlers-Danlos and Muffin syndrome. These things are very rare in real life, but they are very common. If there was an epidemiology of the conditions available on USMLE exams, it will be very different from real life epidemiology. You get tested on the rare things, especially the complex things that are confusing, for example, vasculitis, because that then helps you to think about them and to exclude them just because they are rare and they would require you to pay attention to them for you to pick them. So Muffin syndrome and Ehlers-Danlos syndrome, and that you hopefully will review that in biochemistry in terms of the specific reasons. So Muffin syndrome, Ehlers-Danlos syndrome. The other one that you have to pay attention to is what is the most common infectious cause of aortic dissection, or aortic aneurysms and aortic dissection. infectious cause. It tends to cause, yes, you guys are on fire. Yes, syphilis. Syphilis. So you pay attention to that. And remember, I'm seeing I have probably missed 2 questions. All right, so I see 2 people who had, that is MT and Bernard Serwanga. Hopefully I'm not butchering your name. I'm not looking at the question and answers. Please if you can put your answers in the chat box, so that then, because then it comes live immediately. Please use the chat box. Yes, so syphilis, you need to pay attention to that. If you are given a patient, you're given a patient with chest pain, right? And this chest pain is because of aortic dissection. What symptoms, what can you describe the pain? I mean, this is a very basic question, but let's ask. What kind of pain? What will differentiate pain from aortic dissection from other pains? I think that's the question. It's a straightforward question, but let's just answer it. What would differentiate pain from aortic dissection from other pains? Yeah, you guys got it. So it is pain. It's very severe pain that radiates to the back, right? It's pain that radiates to the back. How does that differ from angina? How does that? Let me tell you something, guys. So those of you who know the name Mogire, I come from Kisii, that is in Western Kenya. I grew up never knowing that there was anything like chest pain, because in our language, we don't have an equivalent language for chest pain. What we have is called ekeuno. And ekeuno is like a blunt force. So I remember when one of my uncles had ekeuno, people gave up on him. And the truth is, he died. He ended up dying. And that's because ekeuno constitutes all kinds of severe chest pain, from pneumonia to aortic dissection. Any pain in the chest in my community is called ekeuno, right? And then, of course, when I came to medical school, that's when I started to realize these pains can be, described differently. That's why chest pain is such an important question, because one symptom can present a ton of things. Another question, which group of patients would present with a heart attack, but they have atypical symptoms? Yes, you guys got it. So the most common group that will have confusing symptoms are those who have multiple comorbidities. So for example, if a patient already has inherent chest pain for some reason, they have neuropathy, or they've had varicella zoster, they have already pre-existing pain, it can be confusing whether this is old pain or new pain. For example, a patient who constantly has gastroesophageal reflux. So patients who already have some form of pre-existing pain. The other category is patients with pleuropsychiatric symptoms, and patients who have difficulties expressing themselves. So there is the question of, can the patient describe the symptoms? But among patients who can describe their symptoms, diabetics will come in, they are having a heart attack, but they don't experience it like other patients. And also women. I have seen several examples when women come in with a heart attack, they have a myocardial infarction, but even the radiation of the pain sometimes can be different. I remember a classic patient who ended up having 100% occlusion of the right coronary artery, but her pain was radiating to the right shoulder, nowhere else, just the right shoulder. And, she was a woman in her late 50s. She wasn't diabetic. So diabetics and women, that's one category. But so that is those who are able to describe their symptoms. But what if they are not able to describe their symptoms? It can be, you know, the elderly or patients with mental health disorders, patients with maybe they have some language deficit. Of course, if they've had a stroke and they can't speak for themselves. But the other category that's confusing is patients who already have pain syndrome. They have diffuse, for example, patients with fibromyalgia. Patients with fibromyalgia will come in complaining of chest pain, but they're also complaining of shoulder pain, back pain, and knee pain. You end up thinking of a complex pain syndrome. And differentiating this chest pain, determining whether it is new pain, whether it is worse than before, whether it has the characteristics. What are the other characteristics of chest pain that makes you think that this is probably related to a heart attack? What are some of the specific things that will steer you to think that this is probably related to a myocardial infarction? Yep. So it cannot. I like your responses. So it cannot. You cannot reproduce that pain. It's worse with exertion. It's relieved by rest. It's relieved by nitroglycerin. It is dull. It's not sharp. It's dull. Somebody mentioned yes, Rita, chest pain with a sense of impending doom, right? And yeah, so let's just quickly review the aortic dissection. So you have there are two types of aortic dissection, type 1 and type 2. Which of the two do you treat medically? Which would require surgery? So the more proximal it is to the heart, the greater the need for surgery. If it's very proximal to the heart, surgery. If it's more distal, you can do medication management. You give beta blockers to slow down the heart rate, because heart rate is the strongest predictor of continued dissection. What is the reason why you do surgery for proximal dissection? The reason why surgery is done for proximal dissection is most of the time related to the shear stress that part of the aorta, from the aortic root, the first about 10 centimeters of the aorta experience, such that if there is dissection there, whenever there is dissection, it causes hemodynamic derangement, which automatically leads to increase in heart rate, and that causes more distress. Therefore, whenever it starts, most of the time it's going to continue. And yes, Janice, you do that to preserve flow into the coronaries, because once that dissection starts coming down, you will cut off blood flow. You will tear off the coronaries. That can continue until you tear off and you end up with a tamponade, right? You end up with tamponade. Abdominal aortic aneurysm. The main question, the main things that you would end up being tested on here is, of course, what's the treatment? It's going to be surgical, but surgery only up to a certain point. Diagnosing it is you have a pulsatile abdominal mass, and the complications, for example, Which renal artery and vein, which renal vein crosses over the aorta? Is it the right or the left? Anatomically speaking. Yes, so the left renal vein crosses in front of the aorta. Under which mesenteric artery does the left renal vein pass? It is the superior mesenteric artery. Therefore, when you have aortic aneurysm, if this is the aneurysm here, and this is the superior mesenteric artery, and in between this space you have the left renal vein, that can be compressed. So that's a common association that you would end up being tested on. Which of the renal arteries rises higher than the other when you think about the renal arteries? Mm-hmm. I'm waiting to see more answers. I've seen left, right. Janice, I've seen your response. Thank you. I'm asking you guys that question because it's important. When you're having dissection, if one of the arteries is going to be affected, it's going to be one of the two. I want you to think anatomically, on which side is the kidney lower than the other side? The clue is on one side you have the liver, on the other side you have the spleen. I think that's an anatomy question. Please put that in mind and go review, and I would like you to please use an image. Don't try to read it theoretically. Use an image. So that's my challenge to you. Number one, look at the drainage. Look at the renal drainage from the scrotum. Renal drainage from the scrotum. One of the veins goes directly into one of the renal veins. One of the veins from the scrotum goes into one of the renal veins, and I would like you to actually look at an image and see, because I don't have any images I would show you, right? One of the renal arteries arises lower than the other. So when you're having dissection that is descending, one of the kidneys is going, and I have had a case where a patient came in with a renal infarction on one side. So this is extremely important. I have seen questions. I've seen questions that test this. So I would like you to do that. Then there is compression of one of the renal veins because of, look at this, where the celiac trunk arises, superior mesenteric artery, the inferior mesenteric artery. Those are, so I'm doing this so that we can move on to the next part. And then the associations of Kaposi sarcoma with HIV/AIDS and chemotherapy patients. And the cherry hemangiomas, it's not here, but cherry hemangiomas usually resolve. Kevin, I've seen your answer. Left gonad vein drains into the left renal vein and may present with hydrocele in case of renal mass obstruction. So Kevin, I would like you to go check, is it hydrocele or varicocele? Is it hydrocele or varicocele? I won't give you, Walter has already, guys are already raining on the parade, but I would like you to actually look at an atlas and see this. It will register in your mind in a way that you will never forget it. All right, guys, we have spent quite a bit of time on vasculitis. I hope you picked something from this area. Cherry hemangioma, if you look at this picture, the cherry hemangioma, the treatment the treatment. Janice, thank you and see you again soon. Thank you very much for your kind words. Cherry hemangioma, any treatment? No. You just need to be able to identify it. If you're questioned on this, and you will most likely see a picture of this. So the things from the skin that you are definitely going to see include this: seborrheic dermatitis, seborrheic keratosis. You will see those. So some of these skin manifestations, you will see if they present papyri, they will present papyri. And remember, of course, which vasculitis will be associated with papyri, particularly Henoch-Schönlein papyra, which is associated with IgA, most often occurs after some GI infection. Cardiac pathology, is Walter on?
Yes. Yes.
I want to see how much more time we have so that I know what section we may have time to review.
I think you can review what we just went through.
Yes.
Then we can give you more time. Then so that we can. Mostly we do it for 1 hour. If we go over, we do 1 hour 20 minutes of the concentration.
Then I think let's just run through what we have reviewed today. That will be it for now. And then we'll link up again another time. All right, so I'm trying to get back to the beginning of this chapter. If you do this with pathoma, you actually know pathoma with the depth of like the kind of review we are doing. By the time you read first aid, it will read like a song to you, which it made my reading of first aid very enjoyable just because I did this. Come on, where? Sorry guys, my computer.
You're almost there.
Yes, all right. Vasculitis, 3 categories: large, medium, and small vessel. Remember, medium vessels are the muscular, and that is the boundary. Large, you're thinking about the aorta and its branches. Then everything else from arterioles all the way is small vessel. Temporal, giant cell arteritis, its association with polymyalgia rheumatica. You have, and remember, these are the same disease. Takayasu and temporal arteritis are the same disease. And one occurs in younger people, that is Takayasu. Giant cell in older people. Giant cell is the only one that can be both intracranial and extracranial. Remember, it can affect anything from the aortic arch itself to its branches all the way up. You do biopsy, you start them on steroids immediately as you plan to do biopsy. Sometimes biopsy can be, you can miss the disease because it's just in certain segments. Same thing with Takayasu. You don't biopsy Takayasu because most of the time it's on the huge blood vessels. You just go ahead and treat. And sometimes Takayasu can present with a differential blood pressure on the upper arms. Like on one side, blood pressure is higher. Sometimes it can lead to no pulse, very low blood pressure on one side, which can be confused with aortic stenosis at some point along those blood vessels. Medium, Polyarteritis Nodosa. I think we went through this quite well. Polyarteritis Nodosa. Polyarteritis Nodosa, multiple organs. It can be on any organ except the lungs. It can be in any organ except the lungs. Kawasaki, coronary arteries, do echo. The whole child is inflamed. Voyager, stop smoking. Period. Then this small vessel vasculitis, please remember the difference between Takayasu and Kawasaki is the age. That's a very big differentiator. Wegenous or Wegenous granulomatosis or cranulomatosis because of the C anchor treated with cyclophosphamide. Vagina will be in the nasopharynx, in the lungs, and in the kidneys. Microscopic polyangiitis, P. ancha, you treat with cyclophosphamide, not to expect hemorrhagic cystitis. It will spare the nasopharynx, but you will have it in the lungs and in the kidneys. Churg-Strauss, it's only limited within the chest. It will affect the heart and the lungs. P. ancha. So P. ancha in Churg-Strauss and in microscopic polyangiitis. And remember the association between Churg-Strauss and asthma. Asthma that is not responding to treatment is possibly Churg-Strauss. Hemlock-Schönlein purpura, IgA, you have purpurae which can be everywhere. Most of the times after you've had a URI, or sometimes because after you've had a GI issue. Hypertension, please remember to review the causes of resistant hypertension. And you're speaking about arterial sclerosis in older people and fibromyalgia, fibromuscular dysplasia, fibromuscular dysplasia in younger people. Yeah, and then arterial sclerosis, please review this. It's, I think this part is fairly straightforward. The thing about this area is that when you review subsequent chapters, a lot of the concepts here you will be called back to. And Mogeni, you will be tested with an image of some sort, something that will be found most of the time in accidents. Remember the most common causes of what predisposes to aortic dissection and or aortic root dilatation, things like Muffin syndrome, Ehlers-Danlos, syphilis, and and the most common murmur that you will find, what's the most common murmur you will find if there is aortic dissection or aortic root dilatation? What's the most common murmur? It is aortic regurgitation. All right, guys, that will be it for today. Hopefully, when we have a session, we will go through some of the these other areas.
Maybe the last thing I should say, Dr. Job.
Yes.
With that cherry hemangioma, it's commonly in the older age, and strawberry hemangiomas, they are common in children. So sometimes they tend to those in the exams. So
yes,
keep an eye on that.
That's an important
difference. Thank you so much, Doctor. Yes. Thank you so much.
Thank you. And I wish you all very well. I appreciate
the presentation today, and I'm gonna look for you. I think you finish up cardiology. We're gonna do an EKG. I don't know if you have free time on 17th. We can talk off this this presentation. Then we see if we can get you on board for the EKG sometime in October.
Yes, I will look at my schedule to see. I've had a crazy one this last 4 weeks, so hopefully going forward, if I'm able to create time, I'm happy to create time. And Pauline, okay. Where is Pauline? I'm looking for you right now after this. I saw you on the...
Yeah, and for everyone else, we're going to have biostatistics next week. So if you can hear me, next week we have biostatistics. I'm sorry, I'm with my kid and she's making a lot of noise.
That is okay.
Yeah.
All right, guys, thank you so much. Logging out just to run somewhere. And yeah.
Thank you. Thank you, guys. See you next week, next Saturday.
Thank you so much.
Absolutely. Fiza, good to meet you here.
Yeah, same.
Yeah.
Take care. I'll end the meeting now.
All right. Bye. Yeah.
Bye.